Please stay tuned to the end of this program or see the show notes for important information regarding today's speakers and the content of this podcast. Hello, everyone, and welcome to another episode of Allergy Talk, a roundup of the latest in the field of allergy and immunology by the American College of Allergy, Asthma, and Immunology. For today's episode, we will be reviewing 3 more articles from the July-August 2021 issue of Allergy Watch, a bi-monthly publication which provides research summaries to college members from the major journals in allergy and immunology. You can also earn CME credit by listening to this podcast. For information or to read archive issues of Allergy Watch, head over to college.acaai.org/publications/allergywatch. And also, make sure you check out the ACAAI community on DocMatter, where we'll make a post where we can continue discussion about the articles discussed today. Well, again, my name is Jerry Lee. I'm the co-host of Allergy Talk. I'm an associate professor at Emory University and the program director, and I'm joined by my 2 co-hosts. First, Dr. Stan Feynman.
Hello, thank you, and glad to be here. I'm currently the editor-in-chief of Allergy Watch. I'm also a past president of the college and in practice here in Atlanta at Atlanta Allergy and Asthma.
And my second co-host is Dr. Maren Kurvilla.
Hi, Jerry. Hi, Stan. I'm Maren Kurvilla, and I am an assistant professor of allergy and immunology at Emory University.
Well, we have 3 more interesting articles that's just telling us more about the field. So we'll start with you, Stan. Looks like years later, after the discovery of alpha-gal, we are starting to learn more about this condition.
Yeah, we are. And this was an article that piqued my interest that Vivian Hernandez Trillo had made comments about in the Allergy Talk. It's from the Annals of Allergy. It's entitled Diagnostic Testing for Galactose Alpha 1,3 Galactose, which we all affectionately know as alpha-gal, in the United States from 2010 to 2018. And basically, as we know, patients with IgE-mediated allergy to galactose alpha 1,3 galactose or alpha-gal, they have this delayed onset allergic reaction after they ingest mammalian meat. And the true burden and the geographic distribution is really emerging of this syndrome. We don't know exactly. We know that it tends to be in the southeast more, but there are other areas that it's significant as well. So this study analyzed the recent US trends in alpha-gal allergy testing and the diagnosis of alpha-gal syndrome. So what it was is a retrospective analysis using over 122,000 specimens from over 105,000 patients who were tested for alpha-gal antibodies from 2010 through 2018. And the study used de-identified data that was provided by the CDC here in Atlanta by the test manufacturer. So it was basically the CDC used the data from the lab. So at least one positive result of alpha-gal was reported in 32.4% of the patients. And positive results were more common in men with 43% versus women with 26%. And it also increased with age. And that kind of goes along with what I see in my practice. I see more men than women, and I usually see it in adults, and I rarely see it in children. The number of tests performed increased during the study period, while the rate of positive results tended to decline in 2018 for some reason. The positivity rate was 29.8% in a total of 26,000 tests, and the positive results were more likely to occur in the summer and fall months, which really makes sense because that's when you're going to see more people outside. They may be working in the garden or walking in a hike and getting bit by ticks, and you're going to see your diagnosis then. More than 2/3, 67.5% of the positive specimens came from the South. By sense and region, they have a nice chart in the paper that's in color, and most of the blues are in the Southeast. The positive rate was between 30 and 34% in the Midwest and the Northeast, but it's only 1.8% in the West. So the highest rate of the positive alpha-gal testing, or 2.35 per 100,000 population, was in Arkansas, Virginia, Kentucky, Oklahoma, and Missouri. And in nearly 80% of the cases of alpha-gal were positive on their first test, which means positive has to be at least over 0.35 kilounits in the test. So from 2010 to 2018, more than 34,000 US patients tested positive for IgE antibodies to alpha-gal. And alpha-gal syndrome does seem to be increasing. It's recognized as a public health problem. The geographic distribution is consistent with the gold star tick, the Amblyopia americanum ticks. And clinicians have to be aware of this, especially, in areas where the lone star tick is, and also in situations where you might have an unexplained anaphylaxis. So when you have patients who have idiopathic anaphylaxis, I think it's really helpful to think of alpha-gal. And what Vivian said in her comment was a high index of clinical suspicion patients without a known cause of anaphylaxis is essential to make this diagnosis.
I took a double take at the people who did not live where ticks are endemic. I don't know, did they talk about why that's happening? Is that just people who just lived in the South and moved north, or is there another cause of alpha-gal? I just wasn't sure why that's happening.
I think you can get it from other ticks, but it has to be a tick type of a problem. I do remember going to an international meeting, and Mike Levine from South Africa presented cases of alpha-gal in Africa where they do not have a lone star tick, but they have other types of ticks, and it's the same type of syndrome. And I cannot remember the name of the tick that he talked about.
I was just going to add that what you mentioned about the percent positive tests coming back have decreased in 2018. To me, that's not surprising because, as you mentioned, Stan, routine incorporation of alpha-gal testing in various diagnostic algorithms for idiopathic anaphylaxis. And so when you cast just such a broad net, the percent positive rate is likely to be a little bit lower.
Well, definitely it's on everyone's radar. And I think, Stan, you see a lot more people who go outside than me.
I just find it such a fascinating syndrome, right? Because I see such interesting patients. So for instance, one of my recent patients with alpha-gal, he actually only has reactions, number one, when he's undergoing severe psychological stress, and number two, when he eats very high fat foods. So if he eats very greasy nachos, then he'll have a reaction. But he's a deer hunter and he's able to eat a lean cut of venison without any problems. So I just thought that was just interesting, right? How pleiotropic these manifestations are and just the triggers. And I've even seen one patient recently whose alpha-gal allergy disappeared, which I always tell people can't happen, but I haven't seen until now.
No, it's interesting you say that because I've seen patients as well. It seems like if they're not bit by ticks on a regular basis, their sensitivity may decline. And it seems like when they get a recent tick bite, then boom, goes up again. So that's something I think to think about. And the other thing you mentioned about the patients coming in, most of the patients diagnose themselves. They come in and they say, I think I have this. So it sort of helps me because as an index of suspicion, I mean, they come in, they've already Googled it because they've looked at their syndrome.
Going back to that fat thing, have you heard of the chylomicron hypothesis? Because there's this association between coronary artery disease and alpha-gal sensitization. And so I remember Tom Platts-Mills brought me aside during the program directors assembly talking about this. And obviously I didn't get to read much about it, but is there a potential delivery of alpha-gal through lipid particles? Does that make sense? This is very theoretical. I'm just hand waving a little bit. And maybe I'm explaining it incorrectly, but like I said, that fat thing you told me just sort of remind me of that.
I've seen people, they say they can't eat a rare hamburger or a rare steak, but something that's overcooked, sometimes they can tolerate. But I don't know I can't speak to the fat.
I even remember seeing, I think, anecdotal case reports published of patients who could not tolerate very high fat dairy products, full cream milk or full cream ice cream even. And I remember I even saw a recent case report, which I was not linking alpha-gal allergy with first dose anaphylaxis to infliximab, because we only think of it in relation to cetuximab. So this was a case report that was published in JACI in Practice a couple of years ago. And I think that it's much more common with cetuximab because of the concentration of alpha-gal, but there are a few reports linking it with infliximab as well. So, and even though alpha-gal is found in several other monoclonal antibodies, the concentration as well as something about the structure, it usually doesn't pose a problem.
Oh man, this continues to confound us.
It's just very, very interesting.
Anyways, that's why this field is so interesting. We're just continuing to learn more and more. Well, I want to just present another food allergy article. Yes, I'm guilty. All right. There's a theme going on here. And this goes to what we have always wondered about, which is, the high risk criteria for at least the NIH for testing for peanut in infancy prior to early introduction was based on the LEAP criteria, which was moderate to severe eczema and egg allergy. But people have always asked, well, what about family history? Family history has been associated with the increased risk of peanut allergy. I remember as a fellow, they told me, hey, you got to remember that there's a 7-fold increase if you have a sibling with peanut allergy. If you have a twin, it's like 64% concordance. So that genetic aspect of peanut allergy, it was like drilled in my head. So when that recommendation came out, there was no family history. They didn't mention it. And so people wonder, well, what is the relationship of family history when we see infants coming to our office and there's a parent, there is a family member, like some family members avoid peanut in that baby because of family history. And so how do we quantify that? Well, this is a very interesting collaborative article that was published in JACI. And it has basically 2 centers collaborate together. There was the Hopkins group and there was the Boston group. And what they did was they took infants who had one of 3 risk factors that were 4 to 11 months. They had either moderate severe eczema, they had a food allergy other than peanut, or they had a family history of peanut allergy, or a combination of the 3. And so you can imagine if you skin test them all, if you challenge them all, you can sort of determine what is the relative contribution of 1, 2, or 3 of these risk factors to the development of peanut allergy risk. So they were able to enroll 321 infants and they all got tested and the majority of them got challenged. And this was really, really interesting. Now let's take each risk factor individually. Moderate to severe eczema, 18% was diagnosed with peanut allergy. Food allergy other than peanut, 19% was diagnosed with peanut allergy. And then family history, if they had one person with peanut allergy, 4% of those were diagnosed with peanut allergy. But as you imagine, some of the infants in the cohort had multiple risk factors. So the most interesting finding is that if you look at family history of peanut allergy, but without eczema, the risk was 1%. So only 1% of the 321 children who had family history of peanut allergy, but not moderate severe eczema, actually was diagnosed with peanut allergy. We're talking about 107 infants who did not have eczema who ended up not having peanut allergy. Very impressive. Now, they didn't have a lot of patients who had food allergy alone without eczema. They only had like 11. Now, none of those actually were diagnosed with peanut allergy. But again, the numbers were a lot smaller. But I guess overall, taken together, it would really raise this to the top here is that moderate to severe eczema appears to be the predominant risk factor. And that if you don't have eczema, even if you had family history, you probably have population risk. And therefore, some of the things that we see with parents understandably concerned, they already have a family history of peanut allergy, we can actually provide reassurance that if their child does not have eczema, that they probably have population risk. And I've actually seen this in practice. I have definitely seen parents with infants who did not have eczema, but they had an older child who had severe food allergies, and the parent is terrified. We challenge that kid in the first year of life, and they do great. They do amazing. And it's hard for the parent to believe, but it just shows you how important the identification and the management and potentially the awareness of how strong of moderate severe eczema is for food allergy, and really how we should really be focusing on that in our efforts, but also provide reassurance to those who are probably okay.
That's a good point, but we still see patients who have siblings who have a peanut allergy and they come in and the moms want them tested before they introduce it. And it's a big challenge because I'm always a little worried when they have a little mild eczema that they might have a little skin test and it may not be clinically relevant. Like you said, you challenge them in your clinic and they do fine.
Exactly. And there was another paper that was published, to Stan's point, a few years ago in JACI in Practice out of Chicago, looking at this very large cohort of food allergic siblings. And only a very small proportion of these patients were both sensitized and reactive. So there was a very high rate of just sensitization, but clinical reactivity was much, much lower. And so this again makes a case against sort of routine screening in these siblings that could result in potential misdiagnosis and unnecessarily avoiding a food.
Yeah, I completely agree with everything that's been said. And again, I really hope that we're using data to reassure our patients and tell them that your next child is different from you or your older child and that sort of thing. And because we can do something about it. So I think a lot of parents are motivated. And again, ever since the LEAP study came out, I think it's really transformed and empowered us to do something about the food allergy epidemic. And that's what's so exciting about it. Well, let's talk about the last article about a biomarker that, is it reliable? Is it not reliable? How should it be used? This is the peripheral eosinophil count in asthma. So, Maren, what have we learned about it?
Yeah, so this was, I thought, sort of something that we all realize, but it's an interesting question. So I'm going to ask you both this question before I start talking about the article. So the question is, how many times do you check someone's blood eosinophil count? Let's just say, assuming that they don't have other biomarkers of type 2 asthma, before deciding that this is not eosinophilic asthma?
Well, let me just tell you that I generally don't check a blood eosinophil count unless they're not under control. And I'm thinking, well, maybe they might be a candidate for some sort of a biologic. And that's when I do a CBC with eosinophil count and usually a total IgE. But I don't routinely get it. I mean, it's interesting that you asked that question. We'll talk later about it because McFadden years ago talked about blood eosinophilia a lot in asthma.
When I look at their historical CBCs, the biggest question in my mind is, what is the context? And what I find is that sometimes the patient was on oral steroids. Do you know what I mean? So I'm really trying to chase, did we get a clean CBC where the patient was not on some sort of steroid that messed up the result? I think that is what I'm obsessed with. Now, admittedly, if I think I have a quote unquote clean result, I do give up on it, but maybe I shouldn't.
So I think that's the take home of this paper, is the intra-individual variability in the blood eosinophil count. And I sort of do what you do too, Jerry. Like, I'll just go back through the historical CBCs. And if I have several that are reassuring, then I probably wouldn't press the issue too much. But this was a paper that was published in JACI in Practice earlier this year, reviewed in Allergy Watch by John Oppenheimer. And it talks about how in clinical trials of anti-eosinophil agents, and often even in clinical practice, we often go by the single blood eosinophil count as the sort of biomarker to identify patients with underlying eosinophil asthma, and in clinical trials as an inclusion criteria for study entry. So the authors looked at a post hoc analysis of two different phase 3 trials of almost 500 patients from the reslizumab studies and looked at the variability of blood eosinophil counts in patients with eosinophilic asthma receiving placebo over 52 weeks. So all patients who were included had to have at least one blood eosinophil count greater than 400 during a 4-week screening period. But they looked at their baseline eosinophil counts and categorized them into 4 different groups: less than 150, 150 to 300, 300 to 400, and greater than 400. More than 3/4 of them at baseline had EOs of greater than 400. And then they looked at the variability of blood eosinophil counts in each patient, and they quantified this by analyzing the proportion of patients that stayed in their own category or shifted between categories. And what they found was that patients did end up shifting frequently between these different categories of eosinophil counts during the year of study. And patients with a baseline blood eosinophil count of greater than 400 receiving placebo were most likely to stay in this category. No surprise there. But among patients in each of the lower 3 eosinophil categories, that is, even in those patients who were less than 150 at baseline, 27 to 56% shifted to greater than 400 cells per microliter at some point during the treatment period. And approximately 50% of this variability was due to fluctuations within individual patients as opposed to differences across the study population. And so it sort of supports this body of evidence suggesting that substantial variations in the blood eosinophil count are common in patients with eosinophilic asthma. And they even tried to answer the question, like they did the sensitivity analysis, looking at exactly how many times we need to check somebody's eosinophil counts before we can deem them as non-eosinophilic. And they estimated, so don't ask me about the exact statistics, but they basically estimated that the total intra-individual variability would be reduced by 26% if you repeat it twice and 35% with 3 repeat regimens. So there is so much, like even in clinical practice, right? Because insurance companies often require evidence of current peripheral eosinophilia. And it's frustrating, especially for people who have a clear history of high blood eosinophil counts in the past. And just because of that one moment in time, their blood eosinophil counts may not necessarily reach the threshold. It doesn't mean that they don't have eosinophilic asthma and that a biologic will not work. And there is literature documenting the discrepancy between blood and sputum eosinophils. And I see this often in practice. And so I do agree with this take-home message, which is that repeated measurements of blood eosinophil counts may be necessary, not just for diagnosing asthmatics, but also to effectively treat them with biologics.
So is there like a interval if we're going to repeat it, or we just sort of just do them at random? I don't even know. Like what?
Right. I don't know, because so what the study did was that they checked the blood eosinophil counts every 4 weeks for the duration of the 52-week study, and then they checked them again at like 90 days after. But yeah, so I don't know. I don't think there's a clear-cut right answer, but I don't think it's unreasonable, clearly, to repeat it maybe a few months down the road if patients with uncontrolled asthma.
Oh, you mean if they don't have the 150 or whatever it is? Yeah, that's probably a good advice. But, generally we don't do CBCs on our patients. It's not something we routinely do. I mean, we don't even draw blood in our office. We have to send them to a lab. So it's a little bit of a complicated thing for the patients to do too. So I certainly wouldn't want to start doing it on a routine basis.
The study was obviously looking at people who had severe eosinophilic asthma. So you can't necessarily extrapolate it to an unselected asthma population, right? So they're looking at patients with severe disease. And I completely agree with you, Stan. Like I wouldn't routinely get biomarker testing unless someone has severe persistent asthma and we're thinking of biologic therapy.
Right. And these were patients on placebo. So they were in the study.
Right.
So they had to get these labs. So it's a totally different, an artificial type clinical situation.
Oh my gosh. Does anyone have non-T2 asthma? It's interesting, right? I mean, I don't want to invoke the tezepelumab study, but maybe that's just the happened to be at entry that they were on the low side. Again, I'm just being a little provocative there, but I think absolutely we shouldn't give up after one CBC. I agree with that. I guess the question is, what does that mean if you're just like chasing eosinophils? Do you let their eczema flare up and then you check it and then now they magically have T2 asthma? I mean, that can't make any sense, does it? So anyways, it's really hard. We need better biomarkers, essentially. That's what I'm saying.
So I think that wraps it up, right?
Yep. I think those are the articles for the day. Well, thank you again for listening. And if you like what you're hearing, please rate our podcast on iTunes. And we do want your feedback, corrections, maybe suggestions for a future episode. Please email that to allergytalk1word@acaai.org. Enjoy the rest of your day, and we'll talk to you next time. The ACAI is presenting this podcast for educational purposes only. It is not medical advice or intended to replace the judgment of a licensed physician. The college is not responsible for any claims related to the procedures, professionals, products, or methods discussed in the podcast, and it does not approve or endorse any products, professional services, or methods that may be referenced.